And with that, we're going to start off our final semester, a final talk of the semester. So Professor Begen is an associate professor of management science in the Ivey Business School at Western University. He's also cross-appointed to the Departments of Statistical and Actuarial Sciences and Epidemiology and Biostats. His research interests are management science and analytics applications, data-driven approaches, and in particular scheduling and operations management in healthcare. He's a certified analytics professional, worked in management consulting before his PhD studies, and a recipient of the Canadian Operational Research Society Practice Prize. And he's currently serving as president of CORS, that's the Canadian Operational Research Society, as well as visiting Ross School here with us for his sabbatical. So thank you for taking time during your sabbatical to give a talk.
Thanks very much.
Appreciate it. Welcome.
Pleasure to be here. Thank you. You guys decide if I can meet the expectations for today's talk, but I'm very pleased to be here. And so this is an ongoing work, so we are really hoping to get feedback and revising the papers. We have multiple projects on this. So this is joint work with the two postdocs, Bachman and Wahid, and one of my colleagues from Ivey, Greg Zari. So today we'll talk about home healthcare scheduling applications and challenges. So one thing that I should note to you is that Ivey is a case-based school, so every class is a case. I usually don't speak more than 5 minutes, and so in this case, hearing my voice for more than 5 minutes is driving me nuts. So we'll make sure you guys ask questions or provide feedback, anything. So feel free to jump in. All right. So home healthcare. What should we understand about home healthcare, or what are the characteristics? First of all, we can think of home healthcare as any kind of healthcare services that people can get in their home without going to a hospital. And you can think that why it could be, getting more attraction nowadays, and it could be some advantages. Because first of all, our hospitals are really cramped, and the healthcare professionals are having difficulty to provide sufficient services. One solution could be, why not treat the patients or provide service in their home? And this is especially interesting because of fast growth in this demand area because of aging population. So, for example, if you look at some stats, I think in Canada more than 2 million people receive home healthcare services in 2012. And Canada is about 1/10 of the United States, so we are talking about 34 million people, and 2 million of them receive the service in a year, so that's quite significant. So the demand for home healthcare is actually growing, so that's one of the challenges. Another one is quality of care. So in their home, patients receive one-to-one care, and it's pursued as higher quality. And in Ontario, due to a survey, majority of the people, about 92%, are really happy with the service they got in home healthcare rather than going to hospital. So they prefer, why? Because it's their home, they know the environment, they don't have to, in a harsh winter, take the bus or drive, or, people are coming and providing services to them. So that's one advantage. And another one is, people talk about is home healthcare services may reduce some hospital-related costs. So some surveys or studies are putting almost 1-to-10 ratio. So it may cost on 1/10 of the service that you get at the hospital if you get that service at home. Of course, we can't get every service at home. Like you can't have cardiac surgery at home. You can't have certain services at home. Like only some of them can be provided. So this is maybe a quick picture of what we are talking about, why this area is getting more and more interest from researchers, practitioners, and everybody else. All right. So what are other, two important decisions in healthcare is planning and scheduling. So for example, things are a little bit different from province to province, and I'm sure it's much different than Canada in the US and vice versa. But the main two questions are, if you're a company or if you're a government organization who's providing these home healthcare services, you got to worry about at least two important things. One of them is planning, the other one is scheduling. So planning is, you need to worry about what kind of resource that you should have. We have like healthcare practitioners, like nurses, for example, but each nurse could be a different class, right? We have different classes of nurses. Some nurses can provide all of the services. Some other nurses maybe can provide only a subset of services. And at the moment, we are not talking about physicians, but in Europe, for example, physicians also go to a patient's home and they visit them at home, and it's quite common practice. My grandfather was a doctor, and then I remember he used to carry his bag everywhere, and then he used to, patients call him and he would go there. But in North America, that seems to be not the norm, but in the future, who knows, maybe things may change. So another aspect is you have to know what type of talent resource or resource pool that you should have. And also you should make the allocation, right? So you have patients, you have resources on which one is going to serve what. So you have to make that high-level decision. And then you have to schedule patient to resource assignment and routing every day. So you have to tell the resource saying that, hey, you're going to see 10 patients tomorrow, and you have to visit them in this order. So, because you need to visit them in this time frame, right? So that's one aspect of it. Another thing is, so a resource has to know what patients to be visiting, and the patients also have different needs. Some patients may need to be visited maybe once a week, the others twice a week, and then the others maybe every day. And maybe they have to be visited every certain day on a certain time. So we have caregivers, we have patients, and we have a depot. Depot could be a hospital where the caregivers may need to go at the beginning of the day, get some supplies, or sometimes they have to go in the middle of the day or at the end of the day to drop off something, such as maybe they take blood samples or some other test results and vice versa. So we may have a depot or not. The caregivers may go directly to the patients from their home, or they may need to go to the depot and go to the patients. So, and the objective of all of that is some sort of, trying to minimize the total cost. And the total cost, we are talking about two things at this moment. So basically, shifts in terms of how many people we should schedule at a certain time. Each shift has a different cost. And if we need to do any overtime. Why? Because the services need to be covered, right? So we can't just, leave patients without unserviced. But then, if we don't have enough resources, some of the resources may need to work overtime, and we like to minimize that. Why? Overtime cost is usually a lot more expensive than regular time cost. So if we can't have it with the regular shift, then we have to do overtime. Any questions or comments so far? So are we clear about the characteristics and what kind of a picture we are trying to look into? So you can think of some of the decisions we need to make is how many resources we should have in each category, how should we allocate them to the patient, and then after that, how should we allocate them to a certain route and assignment so that we'll try to minimize all that. All right. So let's see an example. So we have maybe different homes, these are caregiver homes. We have different homes over here. So in day one, for example, they need to go to depot, grab some things, or actually first from home they go to a patient, another patient. At the end of the day, you have to drop something off. And in the second day, from home they go to this patient again, and then they do this, and another caregiver is doing that. So if you look at this home, for example, visit twice. Why? Because they need to be visited twice. That's part of the requirement. Maybe that's why they're part of this day one and day two, for example, right? So one of the another characteristics of this problem is really they are challenging problems from combinatorial optimization sense. So usually you have to deal with lots of variables. Most of them are binary, and you have to write complicated constraints, and they're difficult to solve. So far we can identify that literature has proposed two approaches to deal with this difficulty. One of them is, instead of solving the real problem, maybe we can relax some of the specifications and see how we can do that. Maybe we can solve a simple problem and hope that that simple problem is approximately good enough so that we can get some insights for the real problem. And the second solution is, instead of searching for entire solution space, we just set some constraints and saying that we're going to be looking into only certain type of solutions, and that's called pattern-based. So, for example, each of my caregivers is going to be doing this particular route. No other particular routes will be will be part of the solution. So that makes the search a lot easier, because then number of points that you need to search is actually decreasing. But of course, then you give up a little bit on optimality. All right, so then if you look at the relaxing problem specification, usually the problem is commonly simplified. So what do we have? We have caregiver eligibility and flexibility. For example, certain caregivers are not eligible to provide certain services. We can relax that. We can assume all the caregivers are homogeneous. They can provide all the services. Then we don't have to worry about this constraint. Another flexibility is some of the caregivers may not be available at certain times, because in Canada, most of these people who are caregivers for the service also have some other full-time jobs, and they do this in the evening or over the weekends to get a little bit more income. So they're not available 24/7 whenever we require that. There's a lot of requirements for some of the services, such as, we may need to visit a patient in the morning to do a certain cycle of treatment, and we may need to visit the same patient again in the afternoon to measure something or to collect another specimen or to get a sample. So we can just ignore those kind of relations as well. And sometimes you may need to visit a patient with two people at the same time, because one person is not sufficient to provide the service. It's difficult. Two people are needed to help the individual for the treatment. And sometimes one caregiver has to visit the patient first, and the second caregiver has to visit just right after. Then we have to schedule that one as well. Delivery and pickup. So again, a certain medicine may need to be delivered, and this medication could be very perishable. So they may need to be taken from the hospital the first thing in the morning, and then they need to be delivered by the end of the day. And at the end of the day, maybe certain items need to be picked up, like blood samples, maybe other type of samples, and it has to be given to lab and etc. So and all this complication may lead us to a multi-depot approach. So you may need to visit a depot multiple times a day. And another complication people talk about in the literature is a transportation mode. Usually, if you are a registered nurse, for example, the healthcare provider companies are reimbursing for your driving your own car. But if you are not a registered nurse, but just a regular, simple caregiver, they don't reimburse your car, and they may say take the bus or do this. But then, of course, then they're losing time on. So the rates for the caregivers could be different. They are provided for transportation and other costs. So this will be, whenever we talk about relaxing the problem, you can forget about all this complication or include some of them, or even simplify even further. Another approach is downsizing the solution space. So, and this seems to be a new practice. So we just we just become aware of a paper in 2015, Transportation Science. I can't remember the name, but the paper is cited 100 times in our paper. So that paper, 2015 Transportation Science paper. So what they approach is, they introduce this like for the home healthcare scheduling. They said, okay, we're going to be looking into this patterns. So for example, one pattern could be visit a patient on Monday, Wednesday, Thursday, Friday. Another one will be Tuesday, Thursday, once a week or twice a week. So you just search your solution space from one of these predetermined patterns, and it turns out that you can solve the problem a lot quicker, because you basically eliminate all the other possible solutions. The good thing is you can get solutions quicker. Bad side is basically you give up on optimality. Yeah, Amy?
So are you scheduling the patients and assigning them to caregivers, or are you just, so in other words, when you say, for example, a pattern might be Monday, Wednesday, Friday, is it that you're determining that I need to be seen Monday, Wednesday, Friday, or that it's going to be the same provider each time?
So ideally, always you want to send the same provider, because of, they get used to them, and it's easier, but sometimes it's not possible. But that could be one of the constraints, that you always say assign the same caregiver to the same patient, no matter what the pattern is. But we can always have that satisfied.
But you're assuming that the patient schedule's already known, right? So in
Yeah,
other words, I
patients-
know that the patient has to be seen
Yeah,
5
but-
times.
Exactly, but
Okay.
the patient schedule is sometimes flexible, like they have to visit twice a week, or they have to visit 5 times a week, right? So
Okay.
then, but there are also some more complicated patients where we have to put more constraints.
Got it, thank you.
Any other questions? All right, so and then basically that's the trade-off between objective function and computation time, right? So if you want to include more solution space, then it takes longer. Otherwise, it's faster. And it limits the allocation to some patients, and actually here in the paper is. So they introduced like 3 different methods, I think I remember, to make this happen. All right. So what we like to do is we can say, hey, look, can we generalize the problem a little bit more and then solve it more efficiently? And we are hoping that we can do this because there are advances in the optimization software, as some of you are already using these things. There are new algorithms such as decomposition for large-scale optimization, so maybe we can divide the problem into multiple stages and solve different problems and combine them together, hope that we'll get a better solution. And the problem structure helps us to do a little bit decomposition and effective modeling. So we can actually maybe create different integer programs and hoping that they are more effective. So I'm not going to go into the detail, but to just give you a sense of, we have some math on the slides. Yeah.
How many people we talking about scheduling? 100, 200, or 3?
It depends from company to company. For instance, in London, Ontario, still I live in, there are 4 companies, and each one of them is serving about several hundreds of customers.
So we're going to schedule all 70. Okay.
Yeah, so at the moment, each company doing is their own scheduling, and the government organization we are working with is called LIN, Local Health Integration Network for Southwestern Ontario. What they're hoping is they're hoping to make the scheduling in one effort, and then tell the companies what they should be doing, because it's going to be a little challenging. Because if you think about London into maybe this area, and then basically somehow Lynn divided the city into 4 areas and then assigned one company each. But sometimes whenever a patient is needed, a patient needs a service, for example, a patient here needs a service, it's been advertised to everybody, every 4 company, and they have a certain algorithm. We don't know the details yet, but that patient is offered to first company. If the first company rejects, then it goes to second and third. And so a company who's serving here may get that patient. So that now they have lots of patients over here, but they also got this patient. And of course, their providers may be living all across different parts of the city, right? So these are the providers for that company. So it's not the best ideal situation where, they have caregivers living everywhere, and then they have patients mostly focused here, but they may get patients out. So it's a little bit complicated, like the Canadian healthcare system, which is free, by the way. That's good. And I have no, I'm glad we have it, but at the same time, you may need to wait 3 years for a hernia operation, because it's not life-threatening. It's not killing you. You may need to wait, but quality is pretty good, as far as I can tell.
What's your time horizon? Are you building a weekly schedule?
That's a good question. I think we do it 4 weeks. We do a weekly schedule, but I think we try to. I think we do 1 week. Yes, we do 1 week. That's good. All right. So if you look at some of the indices, we have patients, caregivers. We have patterns. Right? These are the basically the limited solution space. We have days. I should know how many days, but I suspect it's a week, but it could be more. So these are some indexes. We have a set of eligible patterns for patient J. For example, if a patient needs to be seen twice a week, we can assign them to a pattern where the patient is going to be seen once a week. Set of days in pattern I, and set of eligible caregivers for patient J. And we have parameters such as how everything is deterministic in these models, no stochasticity so far. We have service time, travel time, shift costs for a caregiver class. We have overtime costs for a caregiver class, and then we have service time at the depot, and we have the length of a shift. It's usually 8 hours. All right, and there are two models we can talk about, Model 1 and Model 2. And the difference in Model 2 is the way that you assign your main variable. So in the first one, you basically determine if a patient, for example, J prime is immediately visited after patient J. But in the second one, you just say if patient J is visited after J prime. So second one is a little bit loose. So it has only 3 indices. This one has 4. So you can immediately see this is a more bigger size model, more indices, more constraints. And the Model 2 is a little bit more compact form, but it's a little bit less big. So the model that in 2015 paper, they kind of want the first Model 1 is based on their model, so it's a little bit more generalization of their own model, but Model 2 is a new model. So we think that Model 2 is going to be better, and that's what we created. So the models are looking a little bit complicated, but the main idea is we are trying to minimize the overtime cost and the regular time cost by the number of caregivers we are assigning to certain days. Then we have to make sure that each patient is visited. We have the inflow and outflow constraints, and these constraints basically computing the completion time. So that we can actually find out if you are doing overtime or regular time. Yeah.
How do you take into account that like the caregiver wants to make the most money, but the people scheduling it want to pay them the least money?
I mean, if a caregiver would like to make the most money, right, they have to be available for more number of hours, so they could be scheduled. But then if it's 40 hours is a regular time to work, if they can say I can work 60 hours, then they may get scheduled to 20 hours overtime if needed. But if there are other caregivers available so that the system will not do overtime, the system will not do overtime, right? So they can't schedule somebody because they want to do overtime and overtime. They only do it if it's needed. And the second model is, as you can see, it's a lot simpler, right? It's trying to do the same thing but with different variables here.
Does your model take into account the care that needs to be provided in the home, such as diagnosis, or are you already knowing that, say, wound care patient needs 4 visits the first week, 3 visits the next week?
Second thing, yeah. So the way that we work with at the moment is a patient is seen by a physician, and a physician describes this patient needs this service. And then they say this patient needs this service 3 times a week and this one twice a week. And then we know that information and try to schedule it. So we won't make the diagnosis.
Okay, so it's predetermined by the physician.
Exactly.
And then does this...
And that's why the government actually is paying for that service. So if the physician says this patient needs that in their home, then the government is making sure that they're scheduled that pay. Otherwise, I can't just call them and say, I need this service, and then it won't work.
And then does your model only take into account an RN, or does it take into account a physical therapist?
Yeah, we can have multiple different classes, and then we can make a simplification saying that suppose that, let's assume that everybody can do all the services, but now if we add these constraints, then we're going to need different type of people for different services. Good question. All right, so then if we try to compare the first model and Model 1 and Model 2, we can compare how big they are, dimension, and computation complexity, how fast they are as well. So, and we also compare the performances of these programs on this standard benchmark problem obtained from this paper. And this benchmark has 24 instances and each one of it has 40, 50, 60, 80 patients. So if we just compare in terms of binary variables and number of constraints, Model 2 is a lot smaller. In terms of number of variables, it has 83% less, and then the constraints is only 3% less. Of course, that doesn't guarantee directly it's a better model, but we have to test. Now we just run a simple test. Suppose we're going to run for 3,000 seconds for both models on these standard benchmarks, and these are the basically optimality gaps we obtain. So they are not looking very good, right? So, for example, this says that on average, model 1 is about 45% optimality gap. So that means our solution we are obtaining is almost twice as bad than the optimal solution. Model 2 is about 35%. So there's about 10% gain by just using model 2. So this is the entire idea for showing this exercises. Model 2 on the same instances numerically seems to be doing, if you look at it, seems to be doing better. It's difficult to prove it, but mathematically, but numerically, it's you gain about 10% optimality there. But still, it's not good, right? If the optimal solution is $100, the solution we get on average is $135. All right. Now let's see if we can do better. One idea is using this famous decomposition idea, Bender's decomposition. So what we have here is we basically try to divide the model into two problems: master problem and a sub-problem. So instead of solving like one big problem, let's try to solve two smaller models, and actually maybe many smaller sub-problems. So you start with the master problem, and you compare with the solution of the sub-problem. If they match, then you stop. Then you're good. Then it's an iterative algorithm. Then you don't have to do it. If it's not, then we stop here. If it's not a match, then we have to add some constraints to the original model, and then we solve it. So the idea here is basically instead of solving one big problem, the hope is if you divide and conquer idea, you instead of solving one big problem, you solve a smaller model and then other smaller models and compare the solutions. If they are matching in a certain way, you are happy, you stop. If they are not close enough, then you have to have some constraints so that they're going to match hopefully better in the next iteration. And by doing so, we can solve problems quicker. And now basically the models are going to get even more simplified with less indices. They're going to look very similar, but you're assigning different things. So in the first one, you're basically determining the number of caregivers for each day. You put all the complexity into the submodel where you schedule them on a daily basis. And in a sense that, this is almost mimicking the idea. You do planning, you determine how many caregivers I should have, and then in the second one, I'm assigning them to patients and I assigning to different routes, right? So almost like a tactical scheduling and operational scheduling in the next one. And this one is routing. So basically we have to tell in what order that you should visit each patient for each caregiver. Maybe?
So you have control on a weekly basis over the size of the staff?
Not necessarily. But what we can do is, if we can try to figure out the needs that we're going to need. So we are basically trying to come up with the shifts, right? For each shift, how many people to do. And most of the people who are doing this work is part-time workers. So that I think in that sense we are flexible. So
there's a range of how many?
Yeah. So they are not 100% full-time employees. But then if one idea is if we do this exercise hopefully every week on a regular basis, we can figure out maybe there's a limit that we never gone below, so we can say we can employ this many people all the time and then we can just diverse this shit. We haven't gotten that far yet. Okay. And then this is an optimality cut to make sure that the two models are connected to each other. And if we do this approach, then on the same instances, right, model 1 and model 2, so these are basically no decomposition, nothing, just pure simplex solving it. This decomposition is actually getting an optimality gap of about 3% or 4%, right? So this is quite remarkable in a sense that we can be happy with that with 3,000 seconds. And I think sometimes we get even really good solutions. This instance is tough. As the problem gets bigger, things get more difficult. But now from 35% to this, this is pretty good. That's what we thought. But now another idea is, so this is the non-pattern approach. So what it does is, this is basically if we do the pattern approach. So we still have patterns to choose from, but this one is, we are using the model 1 with no limitation on the patterns at all. We just remove that restriction. We are about 45% optimal. Of course, the solutions are now, the problems are different. So this is presumably harder problem. Why? Because now we search the entire solution space. And model 2 is actually doing better in this non-pattern restriction, and the composition is doing about 4%. So this is quite nice in the sense that even we got rid of the pattern, the solution didn't suffer too much. Okay?
So this is the optimality gap for the specific problem.
For this specific problem.
Right, but in, sorry,
Or
so when you take away the patterns, you
Yeah.
introduce additional opportunities.
exactly.
So how does the objective value in absolute terms change? In other words, I could be within 4% of, if the optimal solution in one case is 100 and
11%.
I'm,
So
there you go.
yeah. So basically, that's the price that we pay to use a pattern approach.
What is this comparing to? Because you don't know an absolute anywhere.
I think in the non-pattern approach, for example, this one we could solve to zero optimality for the non-pattern. So this will be the ultimate thing, right? So there's no restriction on the patterns. But if we solve
Is this the optimality gap, or is this comparing the objective value to each other?
this should be optimality gaps.
Okay, yeah, so I asked the question badly. So
Oh.
if I have more choices,
Yeah.
then the potential answer gets better, right? So
Yeah.
maybe, so I'll give the extreme case to be absurd, right? If without patterns, I could do it for $100 a day,
Right.
and I get a solution of 200, then my optimality gap is really bad. And if the best case when you have patterns is it's 500, and I can do it for $501, my optimality gap is really good.
Exactly. Yeah. Yeah.
But I'd still rather 200 than 501. So how does the actual value of the solution of these compare?
Yeah,
Is
I have
that-
to go back to the runs, but my remembrance was roughly about 10%.
Okay, so it's
So
it's
basically,
not just the optimality gap,
it's not
but there's
optimality gap, but there's value to do non-patterns, which confirms our
that
intuition.
you've got more flexibility.
More flexibility because you don't have to have the patterns. But of course, the idea is, if it's a lot simpler to implement, maybe 10% is the price to pay, right? Because if you try to create a different schedule for everybody every week, all the time, it's going to be challenging to implement. But so that's, I think nowadays I heard some people call this cost of implementation. So they try to include this in the part of the objective function. Actually, that's a cool idea. I haven't seen that. But so what you do is you try to not only minimize the cost of these things, but also there's another term which is the implementation cost, and then maybe you choose the one which is less, which could be you're giving up on optimality, but you're gaining on implementation.
So you're sort of incentivizing things that are more likely to actually happen the way you planned them.
Yeah.
Yeah.
Yes.
Can you explain why the optimality gap is not strictly customer use and the number of patients?
I mean, that's just based on the instances difficulty. These instances are generated by the paper. They are based real world instances. There's no, usually the number of patients gets bigger, the optimality gap usually increases, but that's not always the case. You're going to find that because if you, for example, think the news vendor problem or appointment scheduling problem. So one idea about appointment scheduling is if I'm the patient and you're my doctor and then you tell me, hey, Mehmet, you come and see me at 10 o'clock. I come and see at 10 o'clock, but you're busy with the previous patients, I have to wait. But maybe you are done with the previous patients at 9:30, I won't be coming at 10, you're going to be idle. right? So appointment scheduling problems gets really difficult if this underage cost and overage costs are very close to each other. If they are really apart from each other, it's a lot more easier to solve. So if I arrange the costs differently, but if I increase the number of patients, you can schedule easier. So that's why I suspect the costs make a big gap. Any other questions? All right, so let's try to talk about a little bit more practical issue of the paper we are facing. So now suppose that the algorithm is working in an okay shape. Let's try to actually work on the real problem. In Ontario, this is how things work. So the patients are seen by the physicians, and physicians say, hey, look, this patient requires this type of service every week, every month. This is the frequency, this is what they're requiring to. They're sending that information to this regional branch, which is called, in our case, LIN, which is Local Healthcare Integration Network branch. And what they do is they get this information and then they advertise in their network to, based on a certain algorithm, so that each provider gets a certain number of patients every year. Suppose that the first provider have certain amount of time to make a decision. They either take the patient in or reject the patient. What they do is they look at this kind of argument, how far is the patient from, what kind of services do they require, do I have enough capacity, can I find caregivers, and I know I've seen a paper at a conference, people are working on this problem as well. For a service provider, should they accept the patient or reject the patient based on revenue expectation, right? Each one bring a revenue, but they are also increasing their service load. So should they take it or not? And I think one from University of Toronto, the other one is from York University, have a paper on that. And then if they don't accept, then they go to next, etc. So that's how it works. And our idea is once this assignment is done, can we create a schedule for this guy, for this guy, for this guy? And next step is, can we create a schedule if they were working together for minimizing the cost for this guy? But that's really difficult because these guys may be hesitant to share any information between each other. And so we have to find a way to show value. If we can schedule all of them at the same time, maybe it's going to be better for everyone. Why? Because then hopefully we'll try to assign this patient to another company who's serving this area. And the next question may be, maybe the city should not be divided according to this. Maybe the shapes could be different because maybe there are so many populated areas that they require more services here. It's not fair for this company to get all the services. So these are, future questions. Another one is, so at the moment the providers are using some sort of software to schedule their visits, but we met with these providers and then they complain their software all the time. So because they say current schedules and timetables are not flexible because things change all the time. You can't update them on a regular basis. And we can't really have a stable work schedule for service providers, caregivers. Right? Caregivers would like to know maybe they are working 4 hours or 6 hours or 8 hours a day, a certain time frame, so that they can have other things scheduled in their life. They don't think they're efficient, and the software tools don't take some of the required specifications we talked about. For example, a patient needs to be serviced by the same provider all the time, or we have this synchronized visit and things like that. So now the idea is, can we create a tool that will take all these requirements, such as eligibility, availability, cost rates, and transportation mode. Because if you allow them to drive their own car, it's faster, but then you have to compensate them more for parking and then more costs and things like that. So some of the things we can talk about is more complications. They talked about us about multiple services. So a patient may require multiple services by the same caregiver, multiple caregivers on the same day, multiple non-identical visits. Different providers are providing different type of services. Synchronization, like you need 2 caregivers to do a certain task, and time window, you need to visit the patient from 10 to 12 every day, and then 3 to 5 the other days, for example. So the idea is, we can have just, a caregiver starting from their home, visiting patients going back home, or we can have a depot included, pickup or delivery. Let's try to talk about some of the complications. We are actually working on them right now, trying to model these. So multi-visit service. So here, what needs to be done is, for example, on day one, we require a 60-minute visit, for example, for the same patient. But then between the second visit, we require at least this much time. And after that much time, we don't care where the second visit is going to be, but we just have to make sure that on the same day they are visited twice, and the time between should be at least this much. Another one is sometimes, the requirement is they need to be visited for 120 minutes on a single day, but it doesn't matter if they are visited, 60 minutes, or 30 somewhere. So as long as total number of visits is 120 and there's no specification, then it's good. We can only maybe schedule 120 or 260s, or maybe like say 430 minutes. Another one is each patient has a set of visits, let's say dependency, and independent visits. We talk about, they cannot be done at the same time. We have synchronization, and I'll try to explain them with pictures. So, for example, one requirement is, and this is the setup that we thought that is most generic. Maybe I'll go here this time. And so, if we can model this by the minimum leg time and maximum leg time between these visits, by comparing this measure and that measure, we are able to model most of the things that we mentioned in the previous slide. So this kind of setup allows us flexibility to try to model what should be the different time frame between each type of different visit requirements. Another one is time leg visits. So, for example, one requirement is the minimum number of days between visit K and visit K prime. The other one is the maximum days between K and K prime. So, if you're going to be visited, at least you need to visit 2 days after and at most 5 days within. Right? So, they can be visited in day 3 and day 4 and day 5. So, they have such requirements for some of the patients. If they have this, then by taking an approach in the model that we can take that into account. Another one is the preemptive visits. So, for example, sometimes there is no difference between you schedule a 4-hour visit, just one big visit, versus 1 hour, 4 of those visits during the day. If that's the case, then we can do this, and this is how we can model these 2 parameters, checking to those. And also the synchronized visits can be seen as multiple time leg visits, type 1, and by setting these parameters in 2 slides before it to 0. So with this approach, in a sense that now we know that these guys have to start and finish at the same time, so they have to be synchronized. So by setting these constraints into different values, we can play the requirements of the caregivers. Actually, sorry, requirements of the patients. So, for example, if you look at this one, there is the first visit is going to be taking 60 minutes, and then the second visit is going to be taking 40 minutes, but it's going to be within the first visit, so it's synchronized. The second person is needed only 40 minutes of the 60-minute interval. And this one, that idea could still work, right? So, and then with the same model or different types of models. So the idea is, in this one, for example, the first one already started, the second one arrives a little bit late, they finish at the same time. Again, this finish starts earlier, ends earlier, but then they still have at least 40 minutes within that interval, which is okay, and etc. All right, so I'll try to introduce this model now. So basically here we have the decisions and objective. In the decisions we have patient to day assignment, caregiver to day assignment, patient to caregiver assignment, and routing. So basically sequencing and scheduling. We have to tell them at what order you are visiting which patients. Minimizing regular time, overtime costs, and travel costs. Now we also include the travel costs in this one as well. In the previous one we were just having the overtime costs, so this model is a little bit more comprehensive. It also takes the travel time into account. So from the sequencing point of view, if you have the same patient, time late visits, they don't need sequencing because you're visiting the same patient. But independent visits, which means if you're visiting the patient the next day or then they need sequencing. For the different patients, we need sequencing, right? Only if done on the same caregiver on the same day. Otherwise, we don't need it because it's a different day, maybe presumably different caregiver. Time late visits, although we don't need sequencing, they require scheduling. So we are trying to take the advantage of whenever you can because otherwise the problem is very difficult to solve. This model I'm presenting is a little bit more complicated than the other one, but we still got some preliminary results which we were quite excited about it. I'm skipping the decisions, but the notation, sorry. But basically you can think of like so many variables now because we are taking into account number of caregivers for overtime, regular time, and travel time. And we need to keep track of travel time as well. We need to model these complications. So I'm going to skip the constraints, but this is basically requiring all the things that we talked about, the requirements a little bit. But so at the moment we are hoping to obtain real data for this model, but we just, to run an experiment, we generate some experimental data based on this specification. So we have 15 to 50 patients. We have 8 to 15 caregivers. Service time is uniformly distributed 50 to 90 minutes. Travel time is from 10 to 40. In London, you can get by most of the place for half an hour. Shift cost for caregivers from $200 to $400. And number of visits is from 1 to 4. So we have about 6 to 4 instances, and largest size goes to about 125 visits per week on average. So at the moment we are working on the ethics application, and then they said they have the data. Hopefully we'll get it. We'll see. All right. So at the moment this is maybe the results. So we have the model that I just presented very quickly. If you just saw that mixed integer program that does everything, we get optimality gap of about 33%. But if you use the decomposition idea, that optimality gap drops to about 8%. But this 8% is basically taking all the complexity of the model that they presented. So at the moment we are trying to make this one a little bit better. And we have a couple more ideas to make it a little bit better. I'm not sure if I put them on slide or not, I can't remember, but I'll click on it. All right, I think, okay, good. So first of all, if we can improve our lower bounds in the algorithm, we can get better. We'll see if we're working on getting a better approximation for the total travel time, so we can get a better bound on that. The second one is, the sub-problems are really difficult ones to solve, not the master problems. Master problems are very quick. Because why? The real meat is in the sub-problem. You are doing routing, scheduling, everything. And if you can solve the sub-problems faster, it's going to help tremendously. And one thing that we just tried and we got really good results is we converted the sub-problem integer programs into a constraint program. And it was new to us. We haven't used that before, but we were really stunned with the results. So for this model, constraint programming works a lot faster. So if that's the case, we are hoping that we will be able to get better results. And another idea which we haven't really tried yet is can we use advanced programming language technique to multi-thread the CPU so that we can solve the sub-problem separately. But that's to be determine. All right, so I think that's all I want to say, unless you have any questions or comments. I'm happy to take questions and as well as any feedback. And if you see, I think some of you are coming from maybe practitioners, and if you see this would never work, these are the ideas that we like, these are the things that we didn't like, please tell me.
What's your guess of, and how much this will improve the present situation?
So that's.
And they're doing it now, they're scheduling now, right?
Yeah, they are scheduled now, right? So, but they are complaining about it, by the fact that they have these requirements and they don't have a means to address those requirements. For example, synchronized visits, or try to serve the same patient with the same caregiver. This kind of type of constraints. Hopefully, if we can do those things without increasing the cost and then show them actually we are doing it at a lower cost, I think they'll like it. But the question is, what percentage? I don't know.
Well, you're doing pretty well now with 92% happy people.
That's right, yeah. But that's across Canada, and we are working with London people, and then.
Well, that's the patients who are happy, it might not be the payers who are happy, right?
That's true, yeah. I have no idea what the caregivers. Apparently, caregivers are apparently this is a very tough job. Yeah, and then and it's not very high paid, tough job. So these companies are really having a tough time to recruit people to work for them. So if they can improve from that side, maybe it's going to be a plus. That's the situation in Canada.
Okay, my question is, so far your caregivers are all part-timers, right?
Most of them are part-timers.
Okay,
Yeah.
suppose that you have a full-time caregivers. Do you think your results will be different?
If it's a full-time caregiver, then we have to take into account that we can't probably hire or fire them every week, right? So we have to think. We have to think the next level of, after we figure out how many shifts and how many people we need to cover them by the amount of people that we have. So I think that's a little bit more higher level model where you need to solve this model for significant amount of weeks. You need to figure out at least what level that you need to have a workforce, and you need some flexibility. Maybe you can say, I won't be able to hire everybody full-time, but I'm going to hire some people full-time, some people 50%, some people 25%. So that's solving the next step problem. We haven't got that far yet.
So you said right off the bat that you're not looking at stochasticity, but I'm wondering how variable are the appointment times? Because sometimes it's just quick blood pressure check and off you go, but sometimes if it's a procedure that needs to be performed.
And also travel times.
Yeah, there's that, and also especially if you try to sort of coordinate, two people arriving to see a patient at the same time, or one right after another, how brittle would this become? Might this become?
That's a good question. So that's in our to-do list. So once we get the data, we'll try to look at the variation. You talk to the people, they say, we know travel times are common, but we know. People say something, but the data says something else. So once we look at the data, we'll have a better understanding. We haven't really thought about how this could be converted into a stochastic program, but if necessary, we'll try to do that stuff. If you have any ideas?
Well, what I was curious about, when they make arrangements with the patient, saying, you should expect, a nurse to visit you at this time, do they tell them the time, or do they tell them an hour long range or something like that?
I think they are doing a little bit better than the cable companies, but but they don't specify the hour. They say early morning, late afternoon.
Okay.
Yeah.
Okay, so there's
So there's
some
some
of that
flexibility.
built into it.
Yeah.
Could any of our practitioners comment on the US system? I suspect that there are we know that there are huge differences sort of in general, but are there things that are specific to the home health market?
So, so I got a couple questions for you.
Sure.
So, do the home health clinicians have a standardized assessment that they need to complete, or is it just their own charting method? Or is it
You mean the
another-
caregivers or the companies?
The caregivers.
Caregivers.
Yeah.
That's, I don't know.
Like here we have an ISIS one for what they call an outdoor.
Yeah, I mean, I assume, and then I would think they have to have certain certification, but I don't know what it is.
Because that's what takes a lot of our time to do.
Are we talking about doctors,
And is that
nurses, or just
equivalent
people who
of
help out?
the HR nightmare on the inpatient side?
Which one?
So on the,
In addition to.
It's an individual.
okay,
There's specific.
Care criteria.
So for example, if I was a registered nurse, I can't do home health care without going some certification or training, can I? I don't know, I'm asking.
so but I think that the issue here is, in the US, we're talking a lot right now about how the electronic health record is causing problems because it takes time for me to find the right place to click on the thing, to
Oh,
fill
I
out the
see.
thing, which is largely driven by the payment system. And so one of the things that I think might be different in Canada, I don't know, but we're spending a lot of time filling in drop-down menus and typing things in and documenting them and finding, rather than, sort of the old paper chart where you wrote down the paper, the patient XYZ, you gotta find the right place for all of those things.
I
And
see.
so you're spending time not just doing the work with the patient presumably,
Oh,
but now I have to document this in a particular way, and
Oh, okay.
documentation becomes time consuming.
when doing the home health care and any other thing, okay. Yeah, that part, I'm sorry, but I don't know much
I
details.
just,
Yeah.
so how many visits can a nurse make, number one, or nurse
In-
make
in a day?
an 8-hour day? And then number two, you were talking about not temporary, contingent type people
Yeah.
that can work like, 20 hours or
Yeah.
whatever. How do you keep your continuity, your patient continuity with that same?
Yeah, you don't keep
Yeah.
that much if that happens. And it's not about not number of visits, but we try to say a regular day is 8-hour working day.
Uh-huh.
So if you schedule, say, 8 patients which require 1 hour each versus 2 patients which require 4 hours each, then you just see 2 patients versus 8 patients. It just requires, regular time is like 8 hours a day. But it may be a little bit longer or shorter depending on the stochasticity, or something may go wrong, a patient may get sicker, or but at the moment we ask, there are no emergencies, or there are no, for example, suppose I'm a caregiver, I'm giving this 8 patient and then suddenly I get a call and I need to go usually they don't do that, but that doesn't mean that they never do that. That's we don't know. So these are presumably elective in a sense that they're scheduled. If that happens, probably they take an ambulance and then just ship them to an hospital. What we are hoping is we are almost done with the ethics application. Once we submit this application, they're going to send us the data. If the data is what they think or what they say it is, we'll know answers of these questions a lot better. But
I'm waiting for it.
sure, you bet.
Well, if we can thank our speaker.
No, thank you very much.